All right, everybody, this is Chapter 15, the second half of Chapter 15. We're going to talk about Chapter 15, Sections 6 through 9 on this one. That's anatomy of the ear, physiology of hearing, as well as vestibular sensation, that's that sensation of balance. And then 15.9 is going to be how all the senses work together. So let's start with the anatomy of the ear. And the ear is actually structured into three specific regions: the outer ear, the middle ear, and the inner ear. And all three of these regions actually participate in our sense of hearing, but only part of the inner ear is going to provide for that vestibular sensation, that equilibrium sensation. And while this module in particular focuses on the anatomy of all these structures, okay, we're going to limit function as of right now to hearing. And here you see some of these structures. I'll show this to you now, and then at the end of this section, or as I move through this section rather, I'll show you specific regions that I'm talking about. But here you see a great image outlining the boundaries of the outer ear, and then you see the middle ear is actually basically just from the tympanic membrane to this vestibule, this cochlea region. Okay, so it's basically these auditory ossicles, these bones in your ear. Are the most important things in that middle ear area for you guys to know. And then the inner ear has the cochlea and the semicircular canals, and we'll talk about those as we move through. We begin on the outside of the ear with the outer ear, this external ear. And the most obvious part when you're looking at someone's ears is the auricle or the pinna, okay? And this structure is essentially largely made up of elastic cartilage covered with skin, except for this fleshy lobule at the bottom. And that lobule is actually the most common part of the ear for those piercings. That is that quote-unquote earlobe. It is actually called the lobule. And this auricle's main function is to funnel sound waves into the external auditory canal, or the external acoustic meatus. And this is a task that it does very well because it's essentially a large funnel for these sound waves to funnel them in down to the tympanic membrane. And that is exactly where this canal goes. It is a curved tunnel through the temporal bone that works its way down to the tympanic membrane, also commonly known as the eardrum. And the external acoustic canal is lined with these very modified sweat glands. These are called ceruminous glands, and they secrete a yellowish brownish structure. It could even be gray, and this structure, this yellowish brownish substance known as cerumen or earwax. Okay, and cerumen's main function is to lubricate and waterproof the external auditory canal, as well as the tympanic membrane. But it also traps debris before it reaches the tympanic membrane, and then works to sweep it back out of the auditory canal. In most people, this is going to dry up and exit the canal, but in others, it can actually retain its moisture and build up and interfere with hearing. And I've said this one a couple times, the tympanic membrane is actually just a thin sheet of epithelium and connective tissue that is working to separate the outer ear from the inner ear. It has a cone shape with the tip of it, the apex of it, pointing into the middle ear. So it looks a little bit like a teepee or a tent pointing into the middle ear. And this membrane is essentially what converts sound waves to physical into a form that can be interpreted as action potentials by our brain. So this is a crucial function. This eardrum, this tympanic membrane, is a crucial structure. And you see here everything in the outer ear. You see the auricle, or otherwise called the pinna. And remember that is pretty much everything above the acoustic canal, or I'm sorry, the auditory canal, or the external acoustic meatus. And then down below it, you have that fleshy lobule with no cartilage in it. And then at the very base, what's separating the outer ear from the middle ear is that tympanic membrane. So the outer ear's job is to funnel all those sound waves into the middle ear, right? And the middle ear is a hollow air-filled chamber inside the temporal bone, okay? And this is going to be filled with a mucous membrane. It is, we can think of it as being the area between the eardrum and the wall of the inner ear. The wall of the cochlea would be a better way to say that. The middle ear and the nasopharynx, okay? The nasopharynx is that part of the throat behind the nasal cavity. These are actually connected by a passage called the pharyngotympanic tube. I'm sorry, pharyngotympanic tube, otherwise known as the auditory tube. And this structure's function is to equalize air pressure on both sides of the tympanic membrane. Normally, this tube is collapsed, but it will open briefly when we yawn or when we swallow. Okay, and that's why you'll hear those people telling you chew gum on an airplane, because the difference in air pressure between your middle ear. Okay, so your middle ear hasn't changed air pressure since you've taken off, but your outer ear has become accustomed to the elevated pressure once you're actually in the air. Chewing gum, yawning, swallowing, all of that can encourage that pharyngotympanic tube to open, and when it opens, that air pressure between the environment and the middle ear is going to equalize. Okay, and this helps because any pressure difference will cause the tympanic membrane to stretch, and it'll either bulge inward or outward. And excessive tension can actually reduce the ability of this tympanic membrane to vibrate, and that can cause difficulty in hearing. The pharyngotympanic tube has a potential side effect, though. This is what allows respiratory infection pathogens to make their way up to ears, and we'll discuss that when we look at your clinical A&P portion for otitis media. But as I said, some of the most important structures in the middle ear are the auditory ossicles, and these are actually the smallest bones in the human body, with all three of them fitting about onto the size of your fingernail. And they're named for their shape, okay? The malleus is shaped like a hammer, and this is connected to the apex of the tympanic membrane. So when the tympanic membrane vibrates from sound waves, it is shaking the malleus, okay? Then the malleus actually shakes the incus, or the hammer strikes on the anvil, okay? The incus is also called the anvil. And then those vibrations travel from the incus to the stapes, and the stapes is shaped like a stirrup. And these ossicles are connected by synovial joints, and together, yeah, they work to form a bridge that goes from the middle ear to the inner ear. And so like I said, when the tympanic membrane receives these air vibrations as sound, it shakes the tympanic membrane, and because the malleus is connected to the tympanic membrane, the malleus shakes, and the malleus will shake the incus, and the incus will shake the stapes, and all of these get passed on to the cochlea, where these vibrations work to convert sound waves into fluid movement inside the cochlea. And we'll look at that in a little bit. Now, There are two very small skeletal muscles attached to these ossicles. They're the tensor tympani muscle and the stapedius muscle. The tensor tympani muscle actually has its origin on the walls of the pharyngotympanic tube, and then it's going to insert on the malleus, and it tries to pull the tympanic. I'm sorry, it tries to pull on the tympanic membrane to pull it medially and put some tension on it. The stapedius actually arises from the posterior wall of the middle ear, and then it inserts on the stapes. And this actually works to reduce movement of the ossicles as a whole. And the way these basically work is as a reflex. And let's say you're standing next to some train tracks waiting on your train, and it blows by you, and you hear that loud, prolonged train horn. Well, but if you notice, the initial blast of that sound is going to be much, quote unquote, louder than if it's sustained. And that's because these muscles work together to stop that excessive vibration of these auditory ossicles. And so they're sort of protective for these longer lasting sounds. They do not prevent damage from sudden short sounds like gunshots or anything, but these long-lasting sounds, long-lasting low-frequency sounds like a nearby train, are very crucial for these. These muscles are also contracting just before we speak, and they're also contracting while we chew, so that we've actually evolved to not hear ourselves chew as loudly as we actually do. And I do want to mention that the stapes is connected to another structure in the middle ear called the oval window. And this is actually what's going to form that medial boundary of the middle ear. This oval window is essentially that boundary between the middle ear and the air-filled middle ear and the fluid-filled inner ear. And the vibrations of the stapes then get transferred through this oval window to produce vibrations in the fluid-filled inner ear. And here you see those structures of the middle ear. We've got the tympanic membrane, which remember is not part of the middle ear, it's actually part of the outer ear. But as the tympanic membrane, let's say, vibrates back and forth, it's going to shake and send those vibrations through the malleus, and the malleus is going to strike the incus, and the incus is going to shake and transfer those vibrations down through the stapes, and the stapes is actually covering the oval window in this case. So those are the three auditory ossicles, and then also down here you have, remember, that pharyngotympanic tube, that auditory tube, and it goes down to the nasopharynx. And this is what equalizes pressure between the environment, essentially, the environment, and the middle ear. You also see this tensor tympani muscle arising from the pharyngotympanic tube. And I'm just blacking out these other structures, like for the inner ear, because I want you to be able to focus specifically on what I'm referring to when I say middle ear or outer ear. And I'll do the same when I go to inner ear. I'll black out the middle and inner so that we focus more on the structures I'm discussing. And like I said, we're going to talk about otitis media, which is essentially just an inflammation of the middle ear cavity. And this is most common in children, mostly because their pharyngotympanic tube is shorter and it's more horizontal than those of an adult. These are almost always preceded by an upper respiratory infection, a cold or hay fever, something along those lines. And that bacteria or that viral infection will make its way up the pharyngotympanic tube, and it will begin proliferating in the middle ear. And common symptoms include ear pain, fever, impaired hearing, and most of these patients are irritable, and they may in some cases be nauseous and have vomiting. And there are two different types, essentially, of otitis media. There's acute otitis media, and then there's otitis media with effusion. And we'll talk about acute otitis media first. Now, this is where the pharyngotympanic tube acts as the route for those pathogens to reach the middle ear. And so these pathogens will cause an inflammation, and the inflammation causes a buildup of fluid or pus in the middle ear, and this results in more pressure in the middle ear, and so that interferes with hearing. You'll see some photos that I'll show you in a minute that show a normal tympanic membrane, one with acute otitis media, and then one that has been treated through a procedure known as a laryngotomy. That is essentially where a tube is pushed through the tympanic membrane to allow for drainage. Oh, well, here's the photos. Perfect. So yeah, we have, let me see what'll show up on all these. Say blue. So here we see a perfectly normal tympanic membrane, no inflammation, good coloration. And then if you look over here, this one is very inflamed, and you see it is actually bulging outwards toward us. So that has a bunch of fluid and pus built up behind it, affecting that individual's hearing. If the pressure does get to be too great, the tympanic membrane will potentially rupture, and a rupture is much harder to heal from than an aspiration or a laryngotomy, which brings us to the next photo. A laryngotomy is essentially the insertion of a tube through that tympanic membrane, and that allows the fluid in the middle ear to drain out. And that actually may prevent infection from recurring. Typically, the tympanic membrane heals naturally from this procedure, and it will push the tube out within a year or two. And as I said, children are the most susceptible because their pharyngotympanic tubes are shorter and more horizontal. But they're also susceptible because they get more respiratory infections because their immune systems are immature. And that's just sort of in line with being children. Now, they're commonly treated with antibiotics, although some experts actually wait to see if the infection clears on its own. They don't want to further the propagation of antibiotic-resistant bacteria. But even with treatment, acute otitis media can progress to the second type of otitis media with effusion. And this is otitis media in which an infection has cleared, but that fluid and pus has remained, and it still interferes with the movement of the tympanic membrane. And so this is where we get the laryngotomy or aspiration. They may stick a needle in to physically and mechanically drain the pus or fluid. Typically, they'll do both of those together. They'll aspirate and then they'll laryngotomize the patient. And that just leads to better immediate hearing for the patient. For more immediate post-operation hearing. Now, the inner ear itself is actually a cavity within the temporal bone, and this is going to be subdivided into three regions. You've got the cochlea, the vestibule, and the semicircular canals. Okay, the cochlea is going to basically house the structures involved in hearing, while the vestibule and the semicircular canals work to house structures that detect head movement and position, or that vestibular sensation. And the inner ear is actually sometimes referred to as the bony labyrinth because of its maze-like series of tunnels, okay? And because of the fact that it is made up of bone. But inside of that bone, there's a membrane lining the walls of that bony labyrinth, and that is called the membranous labyrinth. And inside the membranous labyrinth, we find a fluid called endolymph. And this endolymph has a high concentration of potassium ions uh, as opposed to sodium ions, very similar to uh, a, a normal cell's cytosol, like what we saw in the axolemma with high potassium, low sodium inside the axolemma. Well, it's the same here in the endolymph. Between the walls of the bony labyrinth and the membranous labyrinth is a fluid known as the perilymph. A good way to remember that is inside the membranous labyrinth, indo, inside, and then outside or between the bony labyrinth and the membranous is peri. Peri typically refers to around. So this fluid in the perilymph has a higher concentration of sodium as opposed to potassium, and that is going to generally resemble extracellular fluid. And both of these work together, maintaining important roles in transducing sound waves, turning that physical, mechanical sound wave into an electrical action potential. They also work transducing head movements into action potentials as well. Now, the vestibule is located medial to the middle ear. So this is just inside the middle ear. And its wall is what is going to contain that oval window to which the stapes is connected. The vestibule houses two portions of the membranous labyrinth. They are the utricle and the saccule. And these chambers contain receptor cells that detect head tilting as well as linear movement. And these receptor cells transmit that stimuli to neurons that form the vestibular portion of the vestibulocochlear nerve, cranial nerve number 8, if you remember. And now, aside from the vestibule, you'll have the semicircular canals, okay? And the utricle is actually continuous with these three tubes of the membranous labyrinth that make up the semicircular canals. The semicircular canals are the bony labyrinth portion. The semicircular ducts are the membranous labyrinth portion. In this next photo, you guys should note that the anterior, posterior, and lateral ducts are oriented at right angles to one another, and these all work together to detect rotational movement of the head in 3 dimensions. And then at the base of each duct is you're going to find a little swollen bulb called the ampulla. And this ampulla contains receptor cells that contact neurons. Inside, as in the vestibule, these receptor cells are innervated by the vestibular portion of the vestibulocochlear nerve. And so here is what we see when we put it all together there. You'll notice I haven't talked about the cochlea yet. I'm going to do that in just a second. So in the middle, medial to the, I'm going to pick that blue again. Well, the blue is already picked. Let's just go red. So medial to the middle ear, right? We're looking right here. You see that oval window, and what do we see? We see a bony labyrinth on the outside, which is just all of these structures, bony portions. And then inside that, you're going to find the membranous labyrinths, okay? And there is a fluid between them called the perilymph, and the fluid in the membranous labyrinths is the endolymph. So let's say endolymph, perilymph. Gosh, I hope you guys can make that out. So that should maybe clear up a little bit of confusion there. But here you have the bony portion right here of the semicircular canals, and inside that you have the semicircular ducts inside the membranous labyrinth portion. Okay, and then down here you have the ampullae right here. And remember, those are innervated again by the vestibular nerve. And well, that's just how we'll refer to it. You'll notice up here they do split. So this is the vestibular nerve and this is the cochlear nerve. And I haven't talked about this structure yet. I will, I promise. I'll talk about the cochlea in just a minute. But the vestibule itself, you see, breaks down into two sections. The utricle, medial, and just toward the cochlea, you have this chamber called the saccule. So that's the saccule right there. All right, let's talk about the cochlea now. Now let's talk about the cochlea. The first thing I'm going to say about the cochlea is going to be about the round window. It does have this structure that is the round window. It's basically a membrane-covered opening that separates the middle and inner ear. And so I want you guys to remember what the oval window is essentially doing. So as the cochlea is already filled up with this fluid, okay, the stapes pushes on the oval window, increasing that inner pressure, okay? And since the cochlea is made of bone, okay, and the stapes is adding pressure as it pushes in, what this round window actually allows is a sort of pressure relief. As the stapes will push in on the oval window, the round window will push out, equalizing that pressure. And that's honestly, I haven't seen that mentioned in the book, but that is just that it is its function, and it's kind of surprising that it doesn't mention that in the book. But the bony cochlea, you know, it has the round window. And then within the cochlea itself, you're going to find a spiral-shaped portion of the membranous labyrinth known as the cochlear duct, also known as the scala media. And this cochlear duct is connected to the saccule, and it is filled with endolymph. Okay, and you'll see in this image I'm about to show you, the cochlear duct spirals about 2.5 times around a screw-shaped core of bone, and that core of that bony core is called the modiolus or modiolus. And then this ends at the tip of the cochlea. So there are two other chambers that spiral through the cochlea, each one filled with perilymph. So above, superior to the cochlear duct, you have the scala vestibuli, and then this is continuous with the vestibule near the oval window. And then below the cochlear duct, you have the scala tympani, and this ends in the vestibule near the round window. And together, the scala tympani and the scala vestibuli form a sort of sandwich around the cochlear duct, and they're continuous with one another at the tip of the cochlea. So it's all one sort of chamber that is divided into superior and inferior portions, superior being scala vestibuli, inferior being scala tympani. And then you have a sheet of epithelial tissue called the vestibular epithelium. And what this does is it forms the boundary between the cochlear duct and the scala vestibuli. And this membrane separates endo from perilymph, and then it serves as a sort of diffusion barrier between the two for ion diffusion as well as fluid diffusion. These cochlear duct and the scala tympani are separated by a membrane as well. This is the collagenous basilar membrane. Collagenous just means it has a lot of collagen in it. This is a structure connected to a small shelf of bone that projects from the wall of the bony labyrinth. And this basilar membrane is very narrow and stiff at the base of the cochlea, but as it nears the tip, it becomes much wider and more flexible. And this flexibility difference is what is crucial for detecting variations in sound. And the basilar membrane is also super important because it supports the organ of corti, the spiral organ, and these are where our hearing receptor cells are located. They're located within the cochlear duct, which is where the spiral organ is, and this is where energy from sound waves is transduced into electrical action potentials. And then these action potentials get propagated into the central nervous system through the cochlear nerve, the cochlear portion of the vestibulocochlear nerve. And then these cell bodies have the cell bodies of these neurons form the spiral ganglion at the base of the cochlea. So let's take a look at that. And here are these structures that I was talking about. Okay, so the first thing I want to show you is what I was talking about with the oval window. So the stapes is going to press in like this, right? And since everything is already filled with fluid, this membrane here sort of bulges is a better term, bulges outward, so as the pressure is evenly distributed as far as it's supposed to go. You see the modiolus, this bony core here of the cochlea itself. You've got you see, and again, remember it curls about 2.5 times before hitting the tip. But if we look in each of these membranous tunnels here, you'll see the membranous ducts rather. You'll see that it does have this sort of sandwich with the scala vestibuli on top and the scala tympani on the bottom. And both of those are surrounding the scala media, the cochlear duct. Okay, if you want to think of them all as scala, it'll probably be easier to remember just because scala media means the middle scala. And also that has the endolymph, and the two on the outside have the perilymph. So what do we have? We have the spiral ganglion here. Those are the somas for the cochlear nerves, neurons, right? And where do they get their input from? They get their input in from the spiral organ here, and also called the organ of corti. And so these are where those sound waves are transduced into electrical signals and then sent to the central nervous system for processing. The other thing to mention, the vestibular membrane here, separating the scala vestibuli. Oh, look at that, vestibuli, vestibular. Maybe that'll give you a hint for, I know you guys will have to ID this stuff for your lab final, so that maybe that'll be able to help you. And then the scala tympani has the basilar membrane, and the way I always remember that is it's at the base of the cochlear duct. Maybe that'll help you. That's pretty much all of them that we talked about, right? Scala media, scala vestibuli, scala tympani, spiral ganglion, spiral organ, basilar membrane. That's all there. The modiolus is the bony core of the cochlea around which the spiral labyrinth actually spirals around. And now we're going to actually talk about how sound waves are transduced or converted from a physical sound wave into an electrical impulse. We'll also talk about the path of those action potentials and the path of sound conduction, as well as how the different structures of the ear enable that differentiation of pitch and loudness. But the first thing you guys need to be able to understand is how sound works. So just like how I talked about how light works for the eye, Now we have to talk about how sound actually works. So like I said, to understand what is actually happening here, you guys will need to understand sound and appreciate the difference between hearing and sound. Okay, so hearing is the actual cognition process uh, for understanding how sound waves are produced and travel through the air, and then we are then able to be aware of and interpret that sound. The awareness and interpretation is the actual process of hearing. And the truth is, it all starts with sound waves, and these are nothing more than energy waves displacing air molecules in response to an object moving. And so when you speak, the air moving over your vocal cords produces a vibration, and that vibration is then shaped by your tongue, lips, the shape of your mouth, and your and all of that, and it produces a very specific form of air disruption, which then travels hopefully into a person's ear, which then gets processed. But as this sound moves in one direction, okay, away from its source, it's going to compress molecules of air, and that area is an area of slightly increased air pressure, okay? And then when uh, let's say you're plucking a guitar string, if you pluck it, it produces an air pressure in one direction, and then it moves in the opposite direction as well, reduce re- creating an area of lower pressure. So these waves of high pressure and low pressure function one after the other. And although we typically draw sound waves like, well, I'm sure you guys have seen drawings like this to measure. God, that's an awful drawing. I'm sure you guys have seen drawings like that to represent sound waves. And what is actually happening here is that the sound waves don't travel that far from their source. Okay, what happens is let's say there's a poorly drawn guitar here that just looks like a figure eight. Uh, and those strings are plucked there. What is happening is the air molecules near the guitar bump into other air molecules near them, and so on and so forth. It's a sort of domino effect all the way to an area of, let's say, negligibility. Eventually, there's just going to be so much area that these air molecules don't have the energy to bump into the ones next to them, and then that's sort of that dissipation of sound. And that brings us to pitch and loudness, okay? Every sound has a certain pitch. You can hear, the rumble of thunder as a low-pitched sound, and then you have the high-pitched sound of a baby crying. Okay, so pitch or frequency, okay, is determined by how many times an object vibrates back and forth during a certain period. This is also measured in hertz, okay? And this is the number of cycles or vibrations in 1 second. Our ears are typically calibrated to pick up between 20 and 20,000 hertz, or 20 hertz and 20 kilohertz. But the hearing range for other animals is much higher. Like dogs, that's why they're seemingly able to respond to those silent, quote unquote, silent dog whistles. We're even able to feel vibrations of sound. If you've ever stood in front of a concert speaker, you'll feel those vibrations almost hit you in the face. We're able to feel those vibrations between 4 and 16 hertz, even though we couldn't hear them. Elephants and whales, some whales, communicate by producing sounds at frequencies well below 20 hertz as well. Those are those subsonic frequencies. Now that's pitch, but there's also loudness, and loudness can be the measured as the amplitude of a sound wave. This is measured in decibels, okay? And this is the difference between areas of high and low pressure. If if you're playing that guitar and you gently pluck a string, the string only moves a limited distance as it vibrates. And that's the difference between the waves of those high vibrations and those low vibrations, producing the high air pressure and the low air pressure. If you pluck the string very hard, it's going to produce a louder sound because the string is vibrating over a greater distance, displacing more air in the positive and in the negative air pressure phases. As I said, loudness is measured in decibels. Wind rustling some leaves is about 10 decibels, but the jet engine sound, the roar of a jet engine is typically 120 decibels, and this can actually be very painful and damaging to the ears. Great example of sound waves is these string instruments. So this person plucks a string, so that string now vibrates, transferring that energy into the air molecules around it. And you see here, here we have that vibrating string. So as it moves, let's say to the left, okay, it's going to produce this area of high air pressure, right? But on the other hand, it's going to produce an area of negative pressure as it moves in that direction. And then the same is that for the other side. As the string moves to the right, let's use just a different color, purple. So as the string moves to the right, it produces this area of high pressure and then an area of low pressure. I hope that makes sense. If it doesn't, you guys know where my email is. And then we have amplitude and we have frequency and amplitude. So if we talk about frequency, remember that's how many vibrations in a second. So we see very low frequency. We see this sort of slow, sort of low sound. This would be like thunder rumbling. It's producing very few cycles in a second. But you still see those areas of high pressure and low pressure. In a high frequency sound, a car alarm going off, it's going to produce lots of high pressures. It's going to produce lots of vibrations, really, in a second, and that produces lots of those high air pressure and low air pressure regions. Then you have amplitude, and that is really just exactly what it sounds like. It is the force of these waves. It's the difference between the areas of high and low pressure. So you see there's not very much pressure in this, let's say this low plucked guitar string, right? So it's displacing these air molecules, but not very much. So this is a soft sound. When you whisper, you're not displacing as many air molecules, and so it sounds softer. Whereas when you're yelling, you're producing and displacing many more air molecules. Okay, the displacement there is much higher, but the frequency has not changed. You're still producing the same number of vibrations per second. You're just producing vibrations with greater force. So this would be this right here would be a yell, and this would be a whisper. But what actually happens when sound hits the ear? Okay, when these sound waves hit the ear? Well, the vibration has to get funneled down into through our external ear, that cone-shaped auricle into the external acoustic meatus, okay? And if the vibrations are sufficiently strong, they'll vibrate the tympanic membrane, and this movement this moves, remember, those auditory ossicles, and this will cause the oval window to vibrate at the same frequency as the sound waves from the environment. And although the oval window will vibrate at that same frequency, these ossicles actually transmit the force from the larger tympanic membrane to the smaller oval window. And so what this does is it concentrates a sort of broad force into a much more focused area, and it increases that force significantly. And these ossicles actually act as a lever system, amplifying the vibration of the oval window. And it's remember that the vibration of the oval window will generate these waves in the fluid in the inner ear, mostly in the perilymph, in the vestibule, and the scala vestibuli. But because the density of air and these fluids are different, more force is needed to generate those perilymph waves. And so that is really where that increase in force is needed, and that's why these ossicles act as a sort of lever system. And so now this oval window has generated a fluid wave. And this is where that round window comes in. Having that flexible membrane at the very end allows this wave to continue and bulge outward into the middle ear. And this is essential because without it, perilymph doesn't move. Because this fluid cannot be compressed, if it's pushed from one area, it has to move into another area. It's just like squeezing a water balloon. If you squeeze it in one hand, you're going to notice that it bulges outside of your grasp. And so in the same way, when the oval window is pushed into the inner ear, the round window bulges outward. And so this happens vice versa. Like when the stapes stops pressing in and stops vibrating, the round window will press back in to the inner ear, pushing it back out, pushing the oval window back out. Another thing to mention is that these pressure waves actually differentiate. They're not all processed in the same areas. Pressure waves from high frequency vibrations and high frequency sounds, they are only going to travel a short distance into the cochlea, and then this causes the basilar membrane to vibrate where it is narrow and stiff. And what this kind of makes sense if you think about it. This high frequency vibration is going to dissipate very quickly in the fluid and only be able to vibrate a very stiff basilar membrane. Whereas low frequency sounds and low frequency vibrations are able to travel farther into the cochlea, and then this allows it to vibrate the basilar membrane where it is wide and flexible. And then you also have low frequency vibrations, the rumble of an engine, far off thunder. These travel very far into the distal end of the basilar membrane. Let's say, and then you have inaudible sounds, below our frequency of hearing, below 20 hertz. These waves still travel all the way in through your cochlea, and this actually goes all the way back to where the scala vestibuli connects with the scala tympani, and it joins at an area, an opening called the helicotrema. And those ultra low vibrations are going to travel past the helicotrema very often and then produce those vibrations that will push out the round window. This shows you a pretty good example of what I mean. So we have some mixed frequency sounds coming in because you're hearing all sorts of frequencies at all different times. These travel in, they vibrate the tympanic membrane. The tympanic membrane vibrates the auditory ossicles. The stapes pushes in on the oval window, and then that produces those vibrations as those air vibrations as fluid vibrations. And so now you have these high frequency vibrations right here. And what they're going to do is they're going to vibrate the very thin, stiff basilar membrane here. And they're also going to bypass, they're going to take a shortcut back to the round window. Because these basilar membranes are so thin, they're able to sort of take a shortcut, and then they're still going to push out on the round window. Because remember, all these vibrations have to have it's like that the law of thermodynamics. All actions have an equal and opposite reaction. So as these vibrations come in, they have to have this negative vibration in the round window. Okay, so those are high frequency sounds. Then you have the low frequency sounds, these very long waves here, and they travel all the way out here to where the basilar membrane becomes wider and more flexible. And they still vibrate the basilar membrane, and then they go down, and again, they're going to produce that negative vibration there on the round window. And up here, you'll see the helicotrema. This is where the scala vestibuli and the scala tympani connect. At the very tip, you would see right here in the spiraled version of the cochlea. And again, this is just a sort of unrolled version of the cochlea. So this is what that would look like. And this just helps us understand where these vibrations actually occur and how they pass through. But all of this is occurring in this spiraled version. Oops, not don't confuse, not in the semicircular canals, but in the spiraled version, the spiral cochlea. Semicircular canals, remember, those are vestibular sensation, and this is hearing sensation. Now, regardless of which portion of the basilar membrane is vibrating, this causes changes in the spiral organ, which rests on the basilar membrane. And so to understand these changes, we're going to look at what actually happens in the spiral organ in detail. This spiral organ contains receptor cells called hair cells. In inner hair cells, these are grouped into a single row. In outer hair cells, these are grouped into 3 rows. There are 3,500 inner hair cells, and these are your primary detection cells for sound. Each one of these hair cells has microvilli of different lengths called stereocilia. And these project from the cell into the endolymph of the cochlear duct. Typically, they're arranged from tallest to shortest. The stereocilia themselves are very stiff, but they flex at the junction with the cell body. Imagine a joystick. Where the hair cell, the stereocilia would be stiff, but it has a pivot point at the base. Now, what makes these actually bend? Well, the tectorial membrane is a stiff membrane that sits on top of the hair cells so that they're sandwiched between the basilar and tectorial membranes. Now, the stereocilia on the outer hair cells also contact the tectorial membrane, but the stereocilia in the inner hair cells do not. So when this basilar membrane vibrates up and down in response to sound waves, the inner hair cells are going to move with it toward and away from the tectorial membrane. And so that activates and sends these action potentials. It generates these action potentials in the hair cells, and we'll talk about this in just a second. Now, each stereocilium, okay, that's one stereocilia is a stereocilium. Each stereocilium is connected to its neighbor via an elastic filament called a tip link. And so when the tallest stereocilium bends in one direction, all of the other stereocilia of that hair cell are pulled then in the same direction. And here we have an image that may show you what I'm talking about. So here you have those outer hair cells, and remember there are 3 rows of those. And then here you have that 1 row of inner hair cells, and the inner hair cells are going to be your sound detectors. And as this basilar membrane jumps up and down in accordance with the frequency and the sound that vibrates it, this fluid in between the tectorial membrane and the basilar membrane is going to push on those stereocilia, right? And so as each of these sort of vibrates, it's gonna transduce that physical vibration into an electrical action potential. And you see here its synapses with the fibers of the cochlear nerve, which then will send that action potential out to be processed. And here we have an actual micrograph of it, and you can still see the 3 outer hair cells and the 1 inner hair cell all just below this tectorial membrane. So let's actually look at that transduction of physical vibration into electrical action potential. At rest, you see, those hair cells stick up straight. You know, there's no vibration, and the synaptic vesicles are not being pushed toward the end, toward that synaptic cleft to begin exocytizing with the synaptic cleft into the cochlear nerve. But bending the stereocilia opens up potassium channels. And so the potassium is going to rush out, okay? And as you lose those positive potassium channels, you're depolarizing the hair cell, right? And so that depolarized hair cell now generates that local potential, and these receptor cells are usually small enough that a local potential is perfectly fine. And so the depolarization then allows those synaptic vesicles to push out their neurotransmitters, and those neurotransmitters are going to bind to the fibers, these dendrites of the cochlear nerve, and they're going to send that action potential down to where it can then be processed by the CNS. And then when the basilar membrane moves back, okay, away from the tectorial membrane, the stereocilia will bend in the opposite direction. So these tips will then flow from the right, they'll flow back to the left to stand up straight. They'll even hyperpolarize by moving to the left. Now, with these tip links no longer stretched and the potassium ion channels closed, the hair cells hyperpolarize, and this stops the release of neurotransmitters. Now, it's important to mention here that those inner hair cells perform about 90% of the work of detecting sounds. And when I say 90%, I mean that 90% of auditory neurons actually contact inner hair cells, with multiple neurons actually contacting each cell. The outer hair cells are relatively poorly innervated, with 1 neuron contacting multiple cells. Despite this, destruction of the outer hair cells via drugs, or more likely going to super loud concerts, this can actually result in complete deafness. And this is because those outer hair cells have essential roles in increasing the sensitivity of the inner hair cells. And so that will they'll amplify the vibration of the basilar membrane. These outer cells will have motor proteins that allow them to generate forces and enhance the movement of the basilar membrane, even as much as 100 times. We'll talk about that a little bit more when we talk about tinnitus. But now let's talk about the actual path of the action potentials after they leave the hair cells. Obviously, they're going to leave through the cochlear portion of the vestibulocochlear nerve, and then they're going to head to the medulla pons junction, okay? And then they're going to synapse from these cochlear nuclei are going to synapse onto the superior olivary nucleus in the pons. And these neurons work to compare information from both ears, and this helps to determine the location of a sound. So then these auditory stimuli are sent to the inferior colliculus of the midbrain. And so these stimuli are then coordinated with head and trunk movement, and this produces the startle reflex. And so if you've ever heard somebody, sneak up behind you and yell boo, what do? You turn and look at them. That is a reflex. That is a reflex response to unexpected sounds. It's an unconscious movement toward putting your face toward the source of the sound. The auditory stimuli are then relayed to the medial geniculate nucleus of the thalamus. And the thalamus's role in human hearing isn't 100% clear, but it appears to be mostly important for processing combinations of sounds according to their frequency and their time interval. And then after the thalamus is done, it stimulates neurons of the primary auditory cortex in the superior portion of the temporal lobe. As with other sensory cortices, the primary auditory cortex is where our first conscious awareness of sound begins, as well as analysis of its location, pitch, and loudness. And the primary auditory cortex is connected through other parts of the temporal lobe that may be specialized for language, and then it is also connected to the limbic system, and so it has emotional and memory system ties. And that's why specific sounds can trigger certain memories, or specific sounds can make you happy or sad. So here we see that pathway starting at the cochlea. It vibrates the basilar membrane, creates an action potential, sending out through the cochlear nerve, and then once the cochlear nerve joins back up with the vestibular nerve, now it's vestibulocochlear nerve, cranial nerve number 8, and then that travels to what? It travels to those cochlear nuclei. Okay, the cochlear nuclei are going to be in that medulla pons junction. And so once the axons from the cochlear nuclei synapse onto the superior olivary nucleus, that's where you have that startle reflex, right? And so after they're done, after the superior olivary nucleus is done with them, those signals get sent up to the inferior colliculus of the midbrain, and then from the inferior colliculus of the midbrain to the thalamus. And remember, the thalamus's role isn't 100% understood, but after the thalamus is done with it, it sends the signal to the primary auditory cortex, which then can stimulate, the limbic system or various other portions of the brain that may be needed to respond to this sound. What's interesting here is that, unlike some of these senses, impaired hearing, if it's in just one ear, that can be localized to indicate damage to the cochlear nerve, the vestibulocochlear nerve, or structures of that one particular ear, because axons from the cochlear nuclei travel to both sides of the brain. So any damage to the auditory pathway after this point will affect certain aspects of hearing, but not cause hearing loss. A person with damage to the primary auditory cortex, for example, may have trouble determining the location of a sound, but they'll still be able to hear it because stimuli from both ears still reaches the other hemisphere of the brain. But let's talk about tinnitus. Tinnitus is the sensation of hearing noise despite there not being any actual sound occurring. Patients who suffer from tinnitus describe this noise as a ringing, a buzzing, a whistling, or a hissing. And this is not a disease itself, but it's often a symptom of some other underlying condition. And unfortunately, tinnitus is super common. About 20% of adults suffer from some form of tinnitus. Now, the most common cause is hearing loss due to damaged stereocilia of the cochlear hair cells. These damaged stereocilia are often bent or misshapen, so they will depolarize those hair cells enough to release some neurotransmitters onto the cochlear nerve endings. So this causes a sort of phantom sound. Tinnitus may also result from the fusion of the middle ear ossicles, some inflammation or irritation of the tympanic membrane, certain medications, neural pathway damage. Any of these may cause tinnitus. But in many individuals, no one cause is ever identified. In some cases, tinnitus is only temporary. A large dose of aspirin can actually cause temporary tinnitus. But for many people, this tinnitus is permanent, and these patients often get prescribed antidepressant medications, or because this is so frustrating, it can lead to some mental health issues. The other thing that is very common is using a fan or some other source of white noise, something that produces a louder sound than the ringing or the buzzing, something that can overpower these phantom action potentials. And this is especially useful while these patients are sleeping. So deafness is the loss of hearing, and this can be classified into two broad categories. There can either be conduction deafness or sensorineural deafness. Now, conduction deafness or conduction hearing loss is due to a problem in the outer or middle ear, and what this basically is a prevention of the sound waves from reaching the inner ear. Excessive buildups of wax, a middle ear infection, a perforated eardrum, or if those auditory ossicles are fused, these vibrations can't reach the fluid of the inner ear as effectively. There's much less accuracy than there would be. Many forms of conduction hearing loss are temporary, and they can often be repaired or corrected. Cleaning out your ears with a proper ear cleaning tool. You're not supposed to use Q-tips. Or repair of a perforated tympanic membrane. All of these are possible. Now, sensorineural deafness or hearing loss, this is a defect in the cochlea or any of the neural pathways in the cochlear nerve or in the CNS. And there are two subtypes of sensorineural hearing loss, and they differ significantly in terms of cause and treatment. Sensory hearing loss or sensory deafness, this is when the action potentials are completely unable to be generated in the cochlea, and this is usually due to dysfunctional hair cells. Loud sounds, certain medications, these damage hair cells. But we also lose stereocilia as we age, especially those in the proximal part of the cochlea. And those are those high frequency sound detecting stereocilia, remember. So hearing aids can actually help mild to moderate causes of sensory hearing loss. We'll talk about cochlear implants in just a little bit. There's also neural deafness or neural hearing loss, and this occurs when the action potentials fail to propagate. They fail to travel through the cochlear branch of CN8 or to the CNS pathways. Now, these are typically caused by strokes or tumors. One such tumor is an acoustic neuroma, and this could just be this is a tumor outside the brainstem at the junction of the medulla and the pons. Now, cochlear implants are not effective for neural hearing loss because it's not an issue of stimulating a cell. It's not the issue of generating an action potential. It's an issue of that action potential not being able to reach the areas it's supposed to. Especially in more recent years, cochlear implants are sort of becoming more common. This involves a surgical implantation of electrodes that are able to bypass hair cells, and then they directly stimulate the cochlear nerve. And these implants don't fully restore hearing, but a patient with a cochlear nerve is able to perceive enough sound to understand speech or hear warnings like smoke alarms. An implant typically has several components. An external microphone worn just behind the ear. This works to send sounds to a processor. The processor converts those sound waves into electronic signals. And then an external transmitter sends the signals to an internal receiver implanted beneath the skin. And then that internal receiver is going to relay these signals to a long, thin bundle of electrodes that are threaded throughout the cochlea. And these work to stimulate nerve endings of the vestibulocochlear nerve. And the success of these cochlear implants tends to vary. Children that are born deaf or suffer hearing loss shortly after birth, if the implant is inserted before the age of 3, it turns out this period of a child's life is the maximum. It is the period of their life at which they are acquiring the most speech and language proficiencies, and so these children often learn to speak normally. However, relatively normally. However, if a deaf child receives an implant after the age of 9 or an adult receives this implant, it is unlikely that regular speech will develop. Because children and adults who lose their hearing after acquiring speech often do well with cochlear implants because they have that memory of what their voice is supposed to sound like or what language is supposed to sound like. They no longer will typically have to rely solely on sign language or lip reading. But no matter the age, extensive training is required to use an implant successfully. So let's use that example I used for seeing. You're at the beach, you see your friend out on the surf, he's out there on his surfboard. You see people all around you, you hear the ocean waves, people talking, your friend laughing and screaming as he falls off his board. All of these sounds travel through the air as waves that get funneled into your auditory canals by your auricles, right? And then they're transduced into action potentials in the CNS for interpretation. So let's look at them step by step. Number 1, what do we have? We have the ocean waves and your friend laughing as he falls off the board. All of these are producing vibrations, and those vibrations are bumping into the molecules of the air around them, and those molecules bump into the molecules after them, and so on and so forth until those vibrations reach your outer ear. Well, your outer ear catches them and then diverts them down into your external acoustic meatus. Okay, well, after that, those vibrations are going to shake. They're going to shake your tympanic membrane, which is going to shake your stapes. It's going to shake your auditory ossicles, which are going to push in and out on the oval window. And then, depending on their frequency, they're going to be processed in different parts of the cochlea. with high frequency sounds being processed at the proximal end and low frequency sounds being processed at the distal end. Regardless, they're still vibrating the basilar membrane, and as the basilar membrane bumps up and down, it's vibrating those hair cells, and the hair cells transduce those signals down into the nerves of the cochlear, into the cochlear nerve, and the cochlear nerve travels down up into the cochlear nuclei of the pons, and then it goes up into the superior olivary nucleus, and then from there it goes into the inferior colliculus, and then from there it goes into the thalamus, and from the thalamus it goes to the primary auditory cortex, and the primary auditory cortex will then confer with the other parts of the brain to process that sound and formulate a response. So that is hearing in all of its grand glory.
Now let's talk about the vestibular sensation. And this is essentially this sense of equilibrium or balance. And this is going to really depend on input from three different sources. It's going to rely on visual stimuli. It's going to rely on sensory input from proprioceptors in the muscles and joints, providing body position feedback. And then we're also going to rely on information from the vestibular system in the inner ear, mostly in the vestibule and the semicircular canals. And these vestibules and semicircular canals are parts of the inner ear, okay? And these organs detect two types of equilibrium. They measure or detect static and dynamic equilibrium. And the meaning of each is really based on its name. The static equilibrium means stationary or unmoving, and it refers to maintaining balance when the head and body are not moving, but the head itself is tilted. Dynamic means changing or moving, and so this refers to maintaining balance when the head or body is moving. And we're going to look at how the inner ear is going to detect head position and movement, as well as how it maintains static and dynamic equilibrium. Now, static equilibrium is monitored by the utricle and the saccule. And I briefly mentioned these portions before, but they are portions of the membranous labyrinth, and they're located within the vestibule. And each chamber has its own structure known as a macula, or when put together, multiple of these are maculae. And these macula are in the epithelium lining these vestibular walls, and they each contain receptor cells for head position and movement. And these receptor cells are essentially hair cells, very similar to the ones found in the cochlea, except that each cell contains stereocilia as well as one true cilium called a kinocilium. And this is going to be taller than all of the other stereocilia that are present. And the stereocilia and the kinocilium are all embedded in a gelatinous mass known as an otolithic membrane. Okay, and this otolithic membrane is suspended in the endolymph of that chamber. This gets its name, this otolithic membrane gets its name because it contains otoliths, and that in Latin is essentially ear stones. And these are just crystals of calcium carbonate that increase that membrane's density. These hair cells work to release the neurotransmitter glutamate. Right, they work to release the transmitter glutamate continuously onto dendrites of these bipolar neurons, right, that form the vestibular portion of the vestibulocochlear nerve. And as you may have guessed, bending the stereocilia alters the release of glutamate. And so that is then going to change the activity of the vestibular neurons. Now, position response is different in the saccule and the utricle because they're oriented differently. In the utricle, stereocilia are oriented vertically, and when your head is upright and stationary, these stereocilia remain vertical, but they will bend when the head tilts to either side or to the front or back. And then in the saccule, the stereocilia are oriented horizontally. And so when your head is upright and stationary, they remain horizontal, but they bend in response to up and down movements, like when you go from a sitting straight up to a slouched position or vice versa. Any change in that elevation. Now, the essential mechanism for this is as the head tilts, gravity is going to pull on the otolithic membrane, and because the otolithic membrane is being pulled, that is going to bend those stereocilia. Now, if they bend toward the kinocilium, the hair cells will have a local potential and depolarize. Then they release more glutamate, and that increases the number of action potentials produced in the vestibular nerve's axons. If the stereocilia bend away from the kinocilium, the hair cells hyperpolarize and they release less glutamate, reducing the number of action potentials in the vestibular nerve. And so here are those structures I was mentioning. Remember, you have the saccule down here and the utricle here, and inside those you're going to have either vertical or horizontal stereocilia and kinocilium. And you see this tallest one here is the kinocilium, and then all of the other short ones are the stereocilia. Now, let's say in the utricle, with those vertical hair cells, if your head tilts, let's say these are this is a posterior view of these hair cells, and so this would be facing anteriorly. If this person's head tilts to the right, okay, that is an arrow to the right, I promise. If this person's head tilts to the right, then those hair cells are bending away. I'm sorry, those stereocilia are bending away from the kinocilium, and so that means that the action potential, the glutamate release is going to be lessened, and so that is a hair cell hyperpolarization, and so they release less glutamate. Now, if the opposite happens and the head tilts to the left for this person, you see that the stereocilia are going to bend toward that kinocilium, and so then they're going to release more glutamate, and that is a further depolarization of the hair cell. And all of those signals travel along this vestibular portion of cranial nerve number 8, eventually joining back up with the cochlear nerve, becoming vestibular cochlear nerve. And here's an image showing you exactly what I was just saying. So this individual tilts her head to her right, and it bends those stereocilia toward the kinocilium, and you see glutamate production is increased, because this would be your normal glutamate production. It's continuously releasing some, and then the stereocilia bend toward the kinocilium, increasing production. And then she tilts her head back upright, so now the stereocilia are not bent, and so there's no net change here between point A and point B, right? Those are the same, but then if she bends her head in the opposite direction, then the stereocilia are bending away from the kinocilium, right? So they're bending away from them, and so the hair cell is going to hyperpolarize and release less glutamate. You see, this is less glutamate than is being released normally. And that can just adjust how those action potentials are being fired through the vestibular nerve. Now, because there's a utricle and a saccule and the maculae are paired, so there's one in each ear, tilting your head in one direction is going to depolarize hair cells in one ear while hyperpolarizing them in another. And so this increases action potentials in one vestibular nerve, decreasing them in another. The brain interprets this combination of signals to as understanding the tilting of your head in a particular direction. And the utricle and the saccule are also important for detecting linear acceleration. This is a sort of dynamic equilibrium when a person's riding a car or when they're in an elevator. As movement begins, okay, the hair cells move with the rest of the body, but the endolymph and the otolithic membrane do not move immediately because of inertia. Essentially, an object at rest tends to stay at rest. So these the otolithic membrane and the endolymph have that inertial resistance. They want to stay where they initially are, but the rest of the body is moving in a direction, producing a force. And it's a sort of lag behind, is a good way to think of it. Uh, and these maculae are really only sensitive to the changes in rate of this movement and not really the movement itself. Which is just to say that if acceleration is going to stop, the endolymph and the otolithic membrane are going to eventually catch up to the hair cells and no longer bend. What does that mean in practical terms? Well, think about when you're a passenger in a car. If you close your eyes at a stop sign, right, you can feel the acceleration of the car as the driver pulls away from that stop sign. However, eventually, the driver is going to stop accelerating and maintain a steady speed. And that's when it can become difficult to tell if the car is moving unless you open your eyes. So once that steady speed is reached, the endolymph and the otolithic membrane catch up, and you now become put into a rest position. And this inertia concept essentially works in both directions, where if the hair cells and the rest of the body stop, the endolymph and the otolithic membrane are going to continue moving forward, and they're going to bend the hair cells in the direction opposite to what is being accelerated. And so this essentially becomes interpreted as deceleration. A good way to think of it is if you've ever been drinking like a cup without a lid, like you just got your McDonald's and they didn't have a lid for whatever reason. Well, if you suddenly have to slam on the brakes, all that liquid's going to come flying out of the cup, right? Because that liquid has a higher inertial property than the air around it. The same is true for the otolithic membrane and the endolymph. They're going to continue moving while the hair cells and the rest of the body stop. And that's just a negative reaction to acceleration, which would be the deceleration. Something that affects many people, me included, is motion sickness. And these symptoms can be like nausea, dizziness, vomiting, and this can occur during particular types of movement, like riding a car, boat, or roller coaster. And this essentially occurs when the brain receives mismatched sensory information from the eyes and the vestibular system. If you're on a boat and it rocks on the water, your vestibular system is reporting that you're moving. However, your visual system tells you that you're not moving relative to the boat. Similar effects will occur when motion is seen but not felt, like some panoramic movie theaters, like IMAX movie theaters that may simulate movement for the viewer. Some people get motion sick in them. In these cases, the brain is not able to integrate that contradictory information. Despite the pathways not being fully understood, these cases cause those familiar symptoms. Treatments can include certain antihistamines. A scopolamine patch can help deal with it greatly by relieving that nausea feeling. It may also help for some people to sit in the front seat of a car and look at the horizon, or look out into the horizon when they're in a boat. Both of these are able to reduce the amount of conflicting information about movement interpreted by the visual system. Me personally, I'm going to be sick if I ride in a car in a passenger fashion in any way. I actually I don't get sick when I drive, which is interesting. being able to interpret all of that visual information maybe helps that. Now there is a different type of dynamic equilibrium, and this is rotational equilibrium. And this is what's allowing you to maintain your balance during rotational movements like turning your head or spinning in a chair. And these movements are detected by hair cells located in the anterior, posterior, and lateral semicircular ducts of the membranous labyrinth. If you remember, we've talked about the cochlea and the vestibule. Now we're talking about those semicircular canals and the semicircular ducts within them. These three ducts, which contain endolymph, are oriented in order to detect rotation in all three dimensions. They are all connected to the utricle, and near this connection, each one has a swelling called that ampulla. Multiple ampulla are called ampullae. And in each of these ampulla, in each ampullae, in each ampulla, we're going to find a crista ampullaris. And this is essentially a cluster of hair cells as well as supporting cells. Each hair cell is going to have the stereocilia and one kinocilium that are embedded in another gelatinous mass, except this one is called the cupula. There are no calcium carbonate crystals in this one, providing it any density. Despite that, the structure is relatively similar to that of the maculae, and so it is not really surprising to understand that it functions very much like it. When you turn your head, the endolymph is going to lag behind and push on the cupula, and this bends the stereocilia, either increasing or decreasing glutamate in response to whether they're bending toward the kinocilium or away from the kinocilium. The endolymph is going to catch up very quickly during continued rotation, and then when you stop turning your head, the endolymph is going to continue to move, and that bends the cupula in the opposite direction, and this has the opposite effect on glutamate release, and the activity of the neurons there are going to interpret this change to mean that the head rotation has stopped. So again, this is just inertial movement. An object at rest tends to stay at rest, an object in motion tends to stay in motion. And here you see that cupula is this entire structure here. Embedded in it are the hair cells and the supporting cells, while this entire structure down here is the crista ampullaris. Okay, and if you look here, you see all of this is within an ampulla. And all of the ampulla are these swollen bases on these semicircular ducts here. So again, it's going to be the same thing. The hair cells at rest are all vertical. They're not doing anything. They're constantly releasing glutamate. But let's say you're rotating your head. Well, if that produces a motion like this toward, the kinocilium, then it's going to depolarize and push more glutamate out, overstimulating those vestibular nerves. And then let's say the head stops turning. Well, that fluid is still going to be moving, and so it's going to be pushing the cupula in the opposite direction. It's going to push the stereocilia away from the kinocilium, and so now these hair cells are depolarized, and so they're releasing less glutamate, meaning less action potentials are produced. And again, it's going to be the same thing where the brain is going to integrate both ears' inputs to come up with a sensation, in addition with vision, input, and proprioceptive response input. All right, so detecting head movement and position is really only part of the fight here to maintain equilibrium. The brain is constantly receiving and analyzing stimuli, and then it's going to work to coordinate a response. And it could be one of three responses, really. It could be muscle movement to produce a change in posture. Um, let's say you're off balance and you're about to fall. Flailing your arms, when you're doing that, is one of these types of responses to avoid falling when you trip. You can increase cognitive awareness of head position or movement, or you can respond by using compensatory eye movements. Your eye motions can compensate for some of the head movement. And then to produce these responses, the vestibular stimuli need to reach various different regions of the central nervous system. And this is through a very complicated pathway that I'll go ahead and describe. So first, action potentials are created in the vestibular nerve and then transduced down the vestibular cochlear nerve, right? Well, these are going to synapse into the vestibular nuclei located at the pons medulla junction. After that, the vestibular nuclei are going to relay these signals simultaneously to several different areas of the CNS. They're going to send the signals to the thalamus, and after the thalamus, they go to the parietal lobe, and this is for conscious awareness of head motion and position. And at the same time they're doing that, the cranial nerve nuclei are going to coordinate eye movement in response to any head movement. And then also at the same time, the cerebellum and spinal cord, they are working to coordinate muscle movement and maintaining balance in response to any head movement. And so nerves are going to come out from this vestibular nucleus to the cerebellum. It's going to go to the abducens nucleus. It's going to go to the trochlear nucleus. It's going to go to the oculomotor nucleus. It's going to go up to the thalamus, and from the thalamus up into the inferior parietal lobe. And all of this is working at the same time to maintain that sense of balance. And here's that pathway I was talking about. So action potentials are created in the vestibular portion of the vestibulocochlear nerve. They're sent out through cranial nerve number 8 into this vestibular nucleus right here. And this one on the opposite side is going to obviously receive input from the other ear, the other vestibular nucleus. And then after that, after the vestibular nucleus receives those signals, it's simultaneously going to be sending out signals to the cerebellum, all of these various nuclei for other nerves, the thalamus, and the inferior parietal cortex. I'm sorry, the inferior parietal lobe, for the various functions that are needed to maintain that balance. And I already went over these, but this slide will again just show you those for you to review further. All right, so throughout this chapter, you guys have pretty much learned how each of these special senses is going to detect a stimulus, transduce it into an electrical signal, and then send that to the brain for interpretation. But special senses don't function in isolation. They're not going. You're not only smelling something at one time. You're not only seeing something at one time. All of these senses work together to collect and report information simultaneously so that a complete picture can be created by all of the areas of the brain. And so if we remember that image of our friend falling off his surfboard, what we're going to see is that all of our receptors are going to detect and transduce stimuli. That's the first thing that happens. Your olfactory neurons and gustatory cells detect salt in the air and the salty spray on your tongue. Olfactory neurons respond by generating an action potential. Gustatory cells create local potentials, both of which release neurotransmitters. Photoreceptors, your rods and cones in the retina, detect light reflected from waves and from your friend, and they hyperpolarize these cells in response. Decreasing the neurotransmitter release stimulates those bipolar neurons, and those then are able to send their signal through the retinal ganglion. Hair cells in the cochlea, these are going to respond to this energy of sound waves being created, and they're going to release neurotransmitters. Hair cells in the vestibule detect the position and movement of your head, and as you move, also release neurotransmitters. After these neurotransmitters are created, after this transduction of stimulus has happened, the neurons of the cranial nerves now take over. They are transmitting action potentials to the CNS. Olfactory stimuli carried through the olfactory bulb, and then that leads to the olfactory tract. The brainstem is going to be receiving taste, auditory, and vestibular stimuli from the facial, glossopharyngeal, and vagus nerves, as well as the vestibulocochlear nerve. And visual stimuli are transmitted to the thalamus through the optic nerve. After that, neurons are going to synapse pretty much universally in the thalamus, except for those for olfaction. Remember, olfaction bypasses the thalamus. And so each of these has to go to the thalamus, except olfaction, for some sort of subconscious analysis. The thalamus's neurons then project them to primary sensory cortices for sensation. Olfaction usually travels through the olfactory cortex directly to, through the olfactory tract directly to the primary olfactory cortex. So it bypasses the thalamus directly to its cortex. And then awareness of these stimuli is essentially going to occur in those primary sensory cortices. Olfactory cortex and primary gustatory cortex allow you to notice the aroma of the salty air and taste the ocean spray on your lips. The primary visual cortex enables you to see the large wave behind your friend, as well as his frantic movement as he falls off his surfboard. The primary auditory cortex detects and analyzes the sounds of the waves and the gulls and your friend laughing and screaming. And then several regions of the parietal lobe provide awareness that you are sitting upright on your beach towel. After that, the frontal lobe and the limbic system are going to integrate these special senses, with each primary cortical area having significant connections to each of these, allowing you to convert all of this information into some sort of coherent, meaningful picture. With the frontal lobe integrating the taste and smell of the salty air with the sight and sound of the waves, and that enables you to know that you are at the beach. And at the same time, the limbic system integrates your knowledge with memories of past experiences at the beach, and you recognize that the person you see on the surfboard is your friend, not a stranger who actually just went into the water, and you're able to realize that his laughter means that he's safe. This image really breaks it down very simply. Again, we're looking at their friend falling off his surfboard up here. But smell neurons detect and transduce sodium in the salty air, sending those action potentials directly through the olfactory tract to the olfactory cortex in the inferomedial temporal lobe. And then what do we have next? We have taste with gustatory cells detecting and transducing sodium in the salt spray. That gets transduced through the facial nerve, glossopharyngeal nerve, vagus nerve, goes to the brainstem. The brainstem sends it to the thalamus, and the thalamus is then going to send it to the inferior parietal lobe, and especially the insula, allowing you to taste that salty spray in the air. Vision, those photoreceptors, the rods and cones, detect and transduce light reflected from the waves. They carry that signal through the optic nerve to the thalamus. The thalamus sends those signals to the medial occipital lobe, allowing you to see the large waves. Hair cells in the cochlea, they're going to detect and transduce sound waves. That sound wave energy produced by the ocean and your friend, transducing those signals down vestibulocochlear nerve down through into the brainstem, into the thalamus. The thalamus is going to send it to the temporal lobe, where you're able to hear the roar of the waves and actually your friend's laughter. And also here, you're going to have vestibular sensation, where the hair cells in the vestibule detect and transduce the position of your head, and they're going to transduce the same pathway, vestibular cochlear nerve, brainstem, thalamus, but they get processed all not in the temporal lobe, but in the parietal lobe, and that enables you to be aware that you are sitting up on your towel. And then all of these together get forwarded to the frontal lobe so that you notice the air smells salty, you see the wave, you realize the wave is big, and you realize your friend is falling off his surfboard. The limbic system enables you to remember that this is the beach where you had your family vacations every year. You recognize your friend as the person falling off their surfboard. Their laughter tells you that they're safe. And you see the complexity here involved in detecting and processing each type of stimulus, and how integrating it into a meaningful picture seems to happen almost instantly. And this is just another great example of how our nervous system allows us to interact almost flawlessly with our environment. Hopefully, almost flawlessly. That is it for chapter 15. I will see you guys next week for chapter 16.